Welcome to the Skeptic's Guide to Emergency Medicine. Meet 'em, greet 'em, treat 'em, and street 'em. Today's date is July 5th, 2024, and I'm your skeptical host, Ken Milne. The title of today's podcast is Why Can't We Be Friends? Why Can't We Be Friends? Conflict in Emergency Medicine. And our guest skeptic is Dr. Lauren Westifer. She is an assistant professor in the Department of Emergency Medicine at the University of Massachusetts Medical School, Bay State. She is co-founder of Foamcast and a pulmonary embolism and implementation scientist researcher. Dr. Westifer serves as the social media editor and research methodology editor for Annals of Emergency Medicine. Welcome back to the SGEM, Lauren.
Always so happy to be here with you, Ken.
Well, I'm just wondering, are you tired after celebrating your nation's Day of Independence on July 4th?
Well, I have 3 kids under the age of 7, so we all go to bed very early. So I woke up very well rested this morning.
Oh, good. Did you do anything exciting to celebrate? I mean, it's a little early. They're too young to watch Independence Day, which is obviously a great movie.
Yeah, no, bicycling, swimming, real American stuff.
Oh, apple pie and American stuff. Yeah, sounds good. All right, well, we're not here to talk about your independence because, Canada Day just happened July 1st, and we have some Australian guests. I don't even know, does Australia have an Independence Day? Do they have a national holiday? Let's just bring in Dr. Wong early. Dr. Wong, do you guys have a national holiday?
It's very hotly contested. It's a controversial issue, Australia Day. Let's talk about it another time.
Ah, well done. Let's stick to the science. Okay, so Lauren, why don't you give us a case to base this show upon?
So we have a 71-year-old patient with a history of hypertension and well-controlled diabetes mellitus without organ involvement who presents with left lower abdominal pain. He's afebrile, blood pressure 138/70, heart rate 82 beats per minute, oxygen saturation on room air 99%. The patient's afebrile, tolerating oral intake. The ED evaluation in the emergency department reveals an unremarkable chemistry panel, normal renal function, white blood cell count of 10,000. An abdominal pelvic CT demonstrates uncomplicated left-sided diverticulitis. The patient is feeling well enough to go home, and you discharge the patient to home without antibiotics and ask them to follow up with their primary care provider or return if they get worse. In follow-up, the patient's primary care provider is upset that the patient was not started on antibiotics.
Yeah, Lauren, I was just sitting there listening to the presentation. I'm like, oh yeah, no, bread and butter, diverticulitis. The new evidence shows that you don't need to provide everyone with antibiotics and you could do a little shared decision making. But it was that final, you didn't give them antibiotics. And another clinician wasn't too impressed by that. So that's a nice setup because it doesn't have to be about diverticulitis, but in 30 years, I've had some of those situations where another physician wasn't too pleased with the management of a patient. So we've discussed agitation in the emergency department several times on the SGEM, and this has included the use of haloperidol for agitation due to psychosis. That was SGEM445. Droperidol for acute agitation, that was SGEM328, and with the problematic term of excited delirium. We talked about that twice on the SGEM. We did a whole SGEM extra episode and episode 218. We've also done an episode on rudeness and its impact on the medical team and its performance on SGEM 227, and the prevalence of inter-physician professional weight bias. That was 343. One thing we really haven't discussed specifically is the conflict that can happen between clinicians.
Conflict in the workplace is defined as a process beginning when individuals or groups perceive differences and opposition regarding interests, beliefs, or values. Workplace conflicts typically involve task issues, things like disparities in procedures, priorities, or resource allocation, and relationships, socio-emotional issues, and breakdowns in interpersonal interactions.
And in healthcare, conflicts are attributed to factors like incompatible personal motivations, high workload. Yeah, I think we can all relate to working pretty hard in healthcare these days. Stress, Yeah, there's that little thing called COVID-19 and that global pandemic. Role ambiguity and poor leadership. Such conflicts hinder cohesive teamwork and decision making, potentially compromising patient safety. And these conflicts can ultimately lead to moral injury.
Conflicts in the ED often stem from clinical decision making and actions, leading to potential adverse patient events and exacerbating access block issues. While individual studies have identified various factors that contribute to conflict, there's been a lack of comprehensive reviews specific to that emergency department setting.
Understanding the individual, team level, and systemic factors that contribute to conflict among clinicians in the emergency department may provide insights on ways to help efforts to reduce conflicts. All right, well, we're not going to have any conflicts today, Lauren, so just give us a clinical question.
What drives conflict in emergency medicine, and are there strategies to reduce conflict?
And the reference for this?
Tjan et al., Conflict in Emergency Medicine, a Systematic Review, Academic Emergency Medicine, June 2024.
Yeah, it is hot off the press, but it got delayed a little bit because of our national holidays here. All right, let's run through the population. What was the population they were looking at?
Empirical peer-reviewed journal articles written in English about conflict in the emergency department context that answered one of the identified research questions. Participants included emergency department physicians, ED nurses, internal medicine physicians, surgeons, healthcare technicians, managers, and primary care providers.
Yeah, and they excluded studies that didn't really focus on the emergency department context, did not address any specific research questions, non empirical articles such as commentaries and opinion pieces, letters to the editor, and of course, that English or non English exclusion. How about the interventions they were looking for?
Strategies and approaches to managing and resolving conflicts in the emergency department. These included communication training, handovers, standardization protocols, improving admission guidelines, changes in communication systems, and efforts to improve interpersonal and interdepartmental relationships.
And did they compare it to anything?
The strategies for managing conflicts were compared to usual practices in environments where these strategies were not implemented or where sort of traditional methods were used.
And what specific outcomes were they interested in?
There were three main things. First of all, what constitutes conflict in the ED? Second, what factors contribute to conflict in the ED? And then third, what strategies can be employed to address and resolve conflict in the emergency department?
And what type of study was this?
This was a systematic review.
And it also is an SGEM hot off the press. And so it's my pleasure to introduce a couple of the authors. The first introduction will be for Dr. Lee Wong. He's an emergency physician at the Austin Hospital in Melbourne, Australia. He also just got a PhD from Swinburne University, Melbourne, researching lead identity threat in emergency medicine. Well, first of all, congratulations on doing a PhD. That's tough. And welcome to the SGEM.
Thanks so much, Ken, for having me. It's a pleasure to be here.
Did you suffer a lot of conflict? Is this why you got involved in this area of research?
Yeah, it's always interesting to have lived experience. And look, it's always, it's been something that's on my heart to explore all this while, ever since going through emergency training. And now as a consultant or a specialist, it's something that I encounter almost every shift still. So it's something that never ceases to inspire and amaze me.
So you took the lemons and made some lemonade out of it. Is that what you're saying? You experienced lots of conflict in the emergency department and said, you know what, if I'm gonna suffer from all of this, I gotta turn it into a PhD and suffer some more.
That sounds right.
How long did it take for you to do your PhD?
Just literally the first 4 years of COVID. So 4 years.
4 years. You might as well turn COVID into something positive as well. Well, I like that. Yeah, I like that a lot. But we also have the lead author, Timothy Tjan, and he is the lead author on this. He's a medical student currently, and he's in his final year of training at the University of Melbourne. he was doing this research as part of his research project for his third year of medical school. Welcome to the SGEM, Timothy.
Thank you so much, Ken. Appreciate it. Never been on a podcast before, so exciting as well.
Well, this will be the best podcast you've ever been on, then, by definition.
Yeah, but winning by default, always the best.
Let's go with glasses half full, okay? No conflict. And what got you interested in wanting to, do some conflict research?
Well, to be honest, how the research project worked was that I just chose the specialty, and I always enjoyed the emergency department during my rotations. So I just picked the ED, and sort of the topic was given to me, and I mean, even when I first came to look at the topic, I'm like, oh, this is pretty interesting. Like talking about conflict in ED. Like I myself have never been a part of conflict in the ED specifically, but I'm sure it happens a lot, and this is quite an interesting topic. So I'm glad I got it. Yeah.
Well, you have something to look forward to, Timothy. Yeah, conflict in human relationships, I think, is unavoidable. And when we place it into an emergency department setting with all the chaos and pressure and stress and stuff like that, conflicts can arise. But we're going to get to that shortly. So why don't we get the author's conclusions? And Timothy, why don't you read it? You're the lead author. You should read the author's conclusions. Represent your team here. And then we'll go through a quality checklist and some key results. But then we'll bring both of you back and we get to talk nerdy with two of you. So, Timothy, what was your team's conclusions?
All right. So our conclusion was that in emergency medicine, conflict is common and occurs at multiple levels, reflecting the complex interface of tasks and relationships within the emergency department.
Yeah, maybe we should have warned people there just to pull over if they're driving in their car or sit down if they're walking around or on the treadmill. Yeah, in emergency medicine, conflict is common. Wow. That was a groundbreaking result. All right, so let's go through this quality checklist, Lauren. And there's not that many for this type of research. So the first question, the main question being addressed, was it stated clearly?
It sure was.
The search for the studies, was it detailed and exhaustive?
Not as exhaustive as it could have been. It excluded non-English language articles and gray literature, and it was unclear if a medical librarian was used.
Ooh, did you use a medical librarian, Lee?
No, we did all the bookwork ourselves.
Oh, that's hard. Medical librarians are so amazing. I love medical librarians. You got to get a medical librarian involved. They're the best. And the non-English thing, that's a common thing in research. So it's not surprising to see that because it does usually take some additional effort, but also additional funding to properly translate articles. So it's not like we're being critical. We get it. All right. Were the criteria used to select the articles for an inclusion appropriate?
Unsure.
And were the included studies sufficiently valid for this type of question?
Yes.
And do you think the results were similar from study to study?
Yes.
And do you think they paid Timothy and Lee big dollars from, Conflict Inc. or Big Conflict, i.e., were there financial conflicts of interest in this study?
No, Ken, there were no financial conflicts of interest. Big Conflict did not fund this one.
They were not funded prize fighters. Okay, let's run through the results. They included 29 studies in the reviews from multiple countries around the world. What was the key result, Lauren?
Conflict is common in the emergency department, and it arises from multiple factors, and there are some strategies that can manage and reduce conflicts.
All right, so they had, 3 questions they were going to answer. So why don't we go through that in the results sections, and then we'll bring in our guest to talk nerdy. So the first thing that they were trying to answer is, what constitutes conflict in the emergency department?
Conflict in the ED often revolves around task issues, arise during handovers, referrals, admissions, even the diagnostic making process. And the conflicts often revolve around disagreements on clinical decisions, patient management, and then the diagnostic process.
Yeah, this is so important, especially the one about handovers. I had a episode one time where it really wasn't clear who was the most responsible physician during the handover and what really needed to be addressed, what was left undone. And that led to some conflict because I specifically asked, am I the most responsible physician? Is the inpatient team responsible for this? And the clear answer from the emergency physician was this patient was admitted and they were under the inpatient team's care. And of course, the inpatient team didn't share that interpretation of who was in charge of the patient care. So that led to some conflict. But there can also be relationship issues leading to conflict in the ED, and these include breakdowns in interpersonal communication, miscommunication, and personality clashes among healthcare professionals. When you have people involved, you're going to end up having personality differences at some point. Relationship conflicts are often driven by things like distrust, biases, which we all have, and differing attitudes and motivations. All right. The second thing that we're going to try to address, Lauren, was what factors can contribute to conflict in the emergency department?
Conflicts can arise from individual level factors, things like lack of trust or inexperience, as well as team level factors, in group, out group type of bias, patient complexity, and then larger systemic factors. So things like high workload in the department or ambiguous responsibility.
Yeah, I got a complaint from another physician once, and it was a primary care physician, and they were concerned that I hadn't put a circumferential cast on a buccal fracture. And of course, we've covered this multiple times on the SGEM. The evidence doesn't support circumferential casting. And in fact, splinting can be completely appropriate, or a tensor bandage. I believe they call them crepe or a wrap, a tensor bandage in the UK. That was the FORCE trial that was published recently. And that led to a conversation about, that there are other ways that are completely appropriate to treat the same medical condition. And this individual just hadn't been brought up to speed because they didn't practice in the emergency department and this wasn't their area of interest. And so they were concerned that this patient hadn't been treated properly. So that had come up recently as an individual level. And these individual level factors can be a lack of trust. Like, I don't trust that this physician is providing the appropriate care. This can stem from a poor reputation. Maybe this physician has had problems in the past, or personality clashes, or just unfamiliarity among healthcare professionals. Inexperience and lack of confidence can also lead to conflict. Junior doctors and staff with less experience often face communication challenges for fear of making mistakes. But it doesn't always revolve around individuals. It can also be team level issues.
One team level factor is that in group, out group bias. It's like a sort of like a form of what has in some places been called tribalism. So people have specialty identities and it creates an us versus them mentality, like emergency medicine versus surgery or whatever, which can lead to distrust and lack of cooperation.
And you can see that beautifully illustrated in glaucomflecken videos where the cardiologist and the nephrologist seem to come to some conflict with regards to maybe how to manage fluid and fluid overload in someone with congestive heart failure. He points that out in such a humorous way. But other team level factors that can come into play is patient complexity and disposition disagreements. Differing opinions on patient management and the complexity of patient cases can lead to conflicts.
Miscommunication during handovers and then varying preferences for communication timing can also contribute to conflict. In addition, sometimes there are differences in priorities or perspectives and expectations, and the emergency department and other specialties may often have differing goals and approaches, which can sort of lead to disagreements.
Yeah, and I just hope that people listening will realize that there are very few thou shalt do this and thou shalt not do that in medicine. Most of what we do is based on low quality research or low level evidence. And so there's a lot of room for clinical judgment, of course. And in that EBM model where you have the literature informing your care and the clinical experience, you also have to include the patient's values and preferences. And so they can change how a patient's going to be treated or dispositioned from the emergency department. And that's okay. There's a lot of room there for a lot of different types of practice. But the third and final part was about organizational or systemic factors.
Yeah, these organizational or systemic factors can contribute to conflict in the ED because we have a high workload and a lot of time pressure in the emergency department setting. And so there can be stressed and rushed interactions that may be partially driven by high patient volumes and then time constraints. And whenever people are stressed or sort of burned out, that also can lead to conflict based on those sort of the infrastructure.
Yeah, the extreme example I like to give about, the high volume and time pressure, and it's often driven by metrics. There's these metrics that are trying to be achieved. The extreme example I give is the metric used to have a physician review an ECG on a patient that's just been triaged, and they're always pushing these ECGs in your face, and you're right in the middle of something. And so the extreme example is as they slide the ECG under the bathroom door. Okay, come on, just give me a moment here before you slide that ECG under the bathroom door. But other system factors include ambiguous responsibilities after handover. I mentioned one before. Power imbalances on who has the decision-making authority. Our shift culture itself in emergency medicine, which is often different from other specialties, and the physical separation between departments can hinder effective communication and coordination. All right. The third question that they were asking, though, is what strategies can be employed to address and resolve conflict in the ED? And they had a number of them. And so, Lauren, why don't we just go through them quickly? There were 9. So, of course, I added another one to make it twice my favorite number of 5. So there's 10 now. But that 10th one will just be my personal one. It wasn't in the paper. But why don't we just go back and forth quickly? Because I really want to talk nerdy to these two guys. Okay?
All right, providing formal communication and conflict resolution training to staff.
Yeah, that's number 1. Number 2 is implementing standardized communication protocols to improve handover quality and reduce that ambiguity that can happen at handover.
Third would be establishing clear guidelines for referrals and admissions to help aid decision making and reduce disagreements between departments.
And the fourth thing is granting ED doctors expanded admitting rights. Yeah, let us admit patients directly so we don't have to go through all these intermediate steps to improve patient flow and bed availability.
Then implementing systems for real-time updates and closed-loop feedback to ensure clear and accurate communication.
Ooh, and the sixth one, I was excited about this one. Use technology like walkie-talkies and digital translation tools to enhance communication efficiency. I was hoping that there was going to be a universal translator like in Star Trek. Lee, do you guys have a universal translator in Australia? And does it work on Scottish accents?
I would say no, or not yet.
No, nothing can interpret Scott. I love the Scottish accent. Hey Ross, I'm talking to you, Ross. I love Scottish accents. I just can't understand what you're saying.
Number 7 is facilitating shared academic programming, multidisciplinary conferences, and social events to help build relationships.
The eighth is encouraging direct communication and simultaneous bedside evaluation to improve understanding and collaboration. I love that. So a neurologist comes down and they're going to help me evaluate a patient that has some neurologic finding. I join them because I can learn from that experience and watch them. They are so much better than I am at evaluating and doing that part of the physical exam that I take that opportunity. And it's not just neurologists. When any specialist comes down to evaluate a patient that I'm concerned about, I like to do you mind if I just stand here and watch? And so I can observe you and pick up some techniques.
Ninth is providing positive feedback and involving all team members, which includes nurses and technicians, in updates and decision-making processes.
And the 10th and final one that was not included in the paper is just to remember, we're all on team patient. It starts with patient care and it ends with patient care. And if we can center ourselves on our common ground, that we put patients at the center of our decision making, perhaps we can avoid some of these conflicts. But that was just my own personal one, okay, Lee? Let's bring Lee and Timothy back in here, and we're going to ask you 5 nerdy questions. I love talking nerdy. And this just gives us a deeper and richer understanding of your publication and the research area in general. So I'm going to let Lauren go first, and she's going to ask the first nerdy question. And either of you, both of you, can answer the question. Please don't have neither of you answer the question, but both of you, please feel free to opine on it.
All right, the first is about scoping reviews versus systematic reviews. There are several ways of synthesizing data, but two are these two, scoping and systematic reviews. Both study designs use rigorous and transparent methods to comprehensively identify and analyze all of the relevant literature about a research question. Scoping reviews present an overview of potentially large and diverse bodies of literature about a broad topic, and systematic reviews collate empirical evidence from a relatively narrower group of studies with a focused research question. How did you decide to do a systematic review versus a scoping review?
In healthcare, there has been some research on conflict. So we wanted to go really deep and specific to conflict that was just applicable to emergency medicine. So in that sense, rather than a broad sort of scoping type question, we really just wanted to focus on emergency medicine and not just include commentaries and opinions and working papers, but we only wanted to look at empirical studies. So whether it was qualitative, quantitative, or mixed, and that was really the driver for the systematic approach.
It's hard when there's not a lot of research in that area, but part of publishing something like this and hopefully doing this knowledge translation will encourage others to start looking at this area and producing more high quality research so we can be better informed on how to avoid or manage and mitigate conflicts when they come up in the emergency department. Timothy, I know you haven't worked in the emergency department yet as an attending, but have you done rotations or have you done some clerkship in the emergency department and witnessed conflict?
Yeah, definitely. I have done multiple placements during my second and fourth year now, my final year. In terms of conflict, yeah, see that all the time. Like in terms of difficulties with admitting patients. Like for example, as an intern, so first year out of med school, sometimes you're tasked with having a chat with the consultant in a rather difficult specialty. I wouldn't say which, but like sometimes it's just hard. You have to prepare everything beforehand, and there's a lot of kickback. And I guess that's one sort of an example of conflict that I can think of. You'll find often, really often in the ED.
Yeah, I like how you avoided naming the specialty. That was well done. Well done. I'm thinking back to when I was a medical student, and geez, that's time travel. Doodle-doo, doodle-doo, doodle-doo. Back in the prehistoric times, I think it was Jurassic. Yeah, Jurassic time period, and it was really awkward when I watched that attending talking to another attending and the conflict, and I'm like, awkward as I stood there silently at the back of the room or something like that. Challenging. All right. So the second nerdy question we wanted to ask you about was data synthesis. Data synthesis is a pillar of systematic reviews. And, systematic reviews can lead to a meta-analysis, but not all systematic reviews are meta-analyses because you can't mathematically put together the information. And it's important to understand the methods that are used to synthesize the information and the results in any systematic review. So I'm wondering, can you talk more about what methods you used in your publication to synthesize and analyze the data that was available?
To synthesize and analyze the data for our review, we used a few key steps. So first, we did an initial search on PubMed and Web of Science using specific terms like emergency medicine and conflict and other related terms, such as miscommunication or misunderstanding or dispute. And this sort of gave us over 1,200 papers. After removing duplicates, we screened the papers by title and abstract, and then we removed those that didn't meet our inclusion criteria, which are mentioned before. And then we sort of added a couple studies from external sources and sort of narrowed it down to 29 studies. In terms of synthesizing the data itself, we sort of use a narrative approach, which means we summarize the findings from each study. We identified the common themes and sort of integrated the results from both the qualitative and the quantitative studies.
Yeah, and in terms of analysis, it was always going to be a tricky affair trying to analyze, a whole bunch of different qualitative, quantitative mixed method studies. So we did try with a tool called the Mixed Methods Appraisal Tool, which is not, used in non-healthcare research predominantly. So it does critically look and ask 5 questions of each paper, and the questions themselves differ according to the type of methodology used. So from what you can see, most of the included studies, addressed at least 3, 4, or 5 of the questions satisfactorily. So that was the best that you can do for this type of systematic review.
All right, my next question is about certainty. One of the key elements of the PRISMA guidelines for reporting systematic reviews is presenting assessments of the certainty or confidence in the body of the evidence that you end up with. Can you discuss your certainty in the evidence for each of the outcomes?
Look, I think the only certainty is that there's no certainty in terms of a topic like conflict, which is wide-ranging and kind of ambiguous in itself, because the different studies, they all looked at different aspects of conflict, if that makes sense. So some of them did look at the specific things that emergency clinicians do, like refer patients and make diagnoses and so on. Whereas other studies looked at the softer side of work, so the relationships and the stresses and the trust issues. So in that sense, there's less certainty about the outcome of the from our paper. But having said that, I think that just speaks to the nature of conflict in itself, and it's always going to be a tricky thing to address in as a whole.
Helpful, thank you.
Lee, I love how intellectually honest you just were. To be actually coming on and saying, you know what? Yeah, we're not so certain. Often we'll see researchers or people that are reading the literature are overconfident and seem to overinterpret the strength of the evidence and their positions. And gets back to conflict in the emergency department when one clinician is saying, oh, well, you have to do this. And I say, what informs your decision here? And then we go back and actually pull the original article or the original information. And we find often that we're standing on pillars of salt and sand. And so the humility in your statement, I just loved it. It was just so great. So thank you for that.
That's good to hear.
So the fourth question is about the quality of research. Your review involved both a quantitative and qualitative data. And so what did you use to assess the quality of the studies that you included? So what did you use and what was the quality?
Yeah, so that's kind of linked to what I mentioned before, the mixed method appraisal tools to try and, I guess, address the quality of each study. And I can, so that tool has been used, as I said, mostly in non-healthcare settings, but it does ask, a few specific questions of each study. And given that most of the studies were qualitative, I can sort of really briefly go through what type of questions they ask of the study, so you can get a handle of what sort of analysis we've done. So with qualitative studies, they ask 5 questions. The first one is the approach appropriate to answer the research question? Second question is, are the data collection methods adequate to address the question? The third one is, are the findings adequately derived from the data? Fourth, is the interpretation sufficiently substantiated by the data? And then the last question is there coherence between the data collection, analysis, and interpretation? So you can see for studies that employed surveys or semi-structured interviews, most of these would be pretty appropriate to answer questions where they were looking at conflict and the experience of conflict. So in that way, there was quite decent quality of analysis, especially for the qualitative studies. Look, for the quantitative studies, there's no randomized control trial of conflict anywhere in emergency medicine or in the world, I think. So a lot of them were descriptive type studies, and they just looked at some statistical analysis and how many people said this, how many people experienced that, and that's the best that we could get in terms of a systematic review in this.
I'm glad that they had 5 because that's my favorite number. Last question, Lauren.
Yeah, the fifth nerdy question. Here we are. Most of the studies that were included were small and from a single center. Do you think that what you identified are common themes in emergency department conflict and have external validity or transferability outside of where those studies were conducted?
Yeah, I think so. So even though many of the studies were done in single-centered settings and qualitative in nature, I think the identified themes of conflict in DED will probably have external validity. So, like the issues identified, communication breakdowns during handovers, disagreements over patient management, and challenges associated with workload or resource allocation, they're probably quite fundamental to just the nature of emergency medicine worldwide. And also in our study itself, we included a lot of studies from various parts of the world. So these themes sort of resonate across different healthcare systems. And I guess despite the potential limitations of individual studies, sort of the cumulative evidence suggests that these dynamics are quite broadly applicable, I think.
Yeah, I was gonna say it's remarkable actually how, across the world, I think the experience of emergency clinicians is almost universal. But hey, what doesn't kill us will make us stronger, I suppose.
Yeah, there were 29 studies from 12 different countries, I think. And the universality of it, the common theme might be that people are involved. And when you have people involved, conflicts can come up. If you work at a place where there is no conflict and it is all rainbows and unicorns and stuff like that, please send us an email, post it on X, share it on Facebook, Instagram, any of the social media feeds. Let us know where this idyllic place is to work. We'd like to hear from you and why it is so wonderful. So, is there anything else you'd like to say about your publication, Timothy?
Yeah, this is my first publication, so it's super interesting. Great honor to sort of have the privilege of being put as first author. Thanks, Lee, even though you participated in it just as much as I did, I think. So thank you.
That's leadership, Timothy. I get what you're saying. Do you have any future research plans, Timothy, or ideas on where you may go from here?
I'm still quite open to doing doing anything really at this point. ED is a possibility, but internal medicine, so one of the internal medicine specialties, neurology, actually was quite interesting. I quite enjoyed that rotation. So maybe something in that. We'll see. We'll see what the future holds.
That's fantastic. Well, you're off to a great start with publishing this in academic emergency medicine. Lee, is there anything else you would like to say about this publication or the research topic in general?
I would like to think that this paper, even though it's sort of, we know all this stuff, it would help people or providers or listeners out there in terms of analyzing and examining yourself as an individual, and then as part of your team, and then as part of the workplace or the organization that you're in. So, what can you do? And there can be stuff done to address conflict at each of these different levels. And so, hopefully we can make work and emergency medicine a better place at the end of the day.
Do you think that this research could be incorporated into some of the training programs for undergrads, medical students, residency, and even attending physicians so that we could have, less conflict and have more joy in what we do?
Yeah, for sure, and also across disciplines, because how doctors learn in a silo, nurses learn in one, technicians learn in one, and we really need to integrate better across these disciplines, and then subsequent to that, across the specialties which we touched upon. How every specialty you just get funneled into this system, this way of thinking and acting and behaving at work, and we just need to do better to work together because we're not in isolation.
Ah, again, Lee. Oh, my. Speaking to my heart, it's all about team patient. Yes, we're all on the same team.
Team
So we
patient.
should train on the same team. We should work together collectively for the same common goal, and that is for the best interest of the patient. So go team patient. Well, thanks for talking nerdy to us. Lauren, do you want to comment on the author's conclusions and compare them to the SGEM's conclusions without getting into conflict?
We agree with the author's conclusions.
All right. How about an SGEM bottom line?
Conflict in the emergency department may arise through several different pathways. Bias, burnout, culture, and local protocols for treatment and disposition may help mitigate conflict.
And can you resolve that case that you presented with the diverticulitis patient, that they were worked up and it was completely reasonable? And the major guidelines, of course, recommend that it's reasonable to treat uncomplicated diverticulitis as long as they have a certain clinical picture without antibiotics. But the feedback that was got from another clinician.
The emergency physician works with the department, gastroenterology, primary care, and surgery to create buy-in on a diverticulitis protocol that adheres to recent guidelines recommending the select use of antibiotics in uncomplicated diverticulitis.
Yeah, see how we did a sort of a meta thing there? We're talking about conflict, but we're also sneaking in some stuff on diverticulitis and the management of diverticulitis. Well
I know
done.
this was a real case, Ken. This was my case.
Oh, okay. Was it? Sorry,
Yeah,
hypothetical. It was hypothetical.
hypothetical.
Don't you have rules down there about that stuff?
Oh, I'm
Okay,
just
yeah.
saying that we created this because there was conflict. We created this type of protocol. The case is totally made up.
Of course, yes. All right. How about the clinical application then?
Conflict may arise from personal, team, and institutional level factors, and departments could consider ways to create a culture of shared respect, information sharing, and examining where local conflict occurs, maybe at that specific site, to create tailored solutions.
And what happens with the conversation between the clinician and the patient? What are you going to tell them?
So many physicians may disagree with patient care or disposition treatments based on expertise, experience, understanding of the evidence, as well as other sort of operational features. In many cases, or most cases, there are several reasonable treatment pathways, and clinicians may just be more comfortable with one or the other. It has nothing to do with the patient. We're working to address systemic issues to address this.
Yeah, it's nice that the patient knows that there's more than one correct way to treat the same clinical situation. Absolutely. All right, well, it's time to announce the Keener contest winner. And the last episode that had a question, it was another win for Dr. Steven Steltz. Now, he's from New Zealand and he keeps listening and keeps winning. So thank you very much, Steven, for being such a supporter of the SGEM. He knew that the ideal location to obtain arterial access for Reboa is the common femoral artery. Lauren, what's the question for this episode?
What is the name of the conflict resolution strategy that involves both parties working together to find a mutually beneficial solution?
And if you know that, then send an email to the sgem@gmail.com with Keener in the subject line. The first correct answer will get a big shout out on the show, plus a cool skeptical prize.
Now it's your turn, SGEMers. What do you think of this study of ED conflict? Tweet or X your comments using hashtag SGEMHop. What questions do you have for this study team? Ask them on the SGEM blog. The best social media feedback will get published in Academic Emergency Medicine.
Yeah, maybe we can demonstrate that you can have productive conversations on social media. We'll see. We'll see. We are social media.
No conflict there, Ken.
Well, but we are social media. We have a locus of control. We can control how we respond, who we respond to, those types of things. It doesn't have to, respond to tone and vitriol. It can be productive. But thanks, Lauren. I really appreciate you coming back on the SGEM and doing it. And happy birthday to your country.
Of course. And I thought that this was a great episode because I really liked what you said, Lee, about like a lot of it involves introspection. And it's so easy to be like, well, there are these other systemic things and the conflict is all there versus like, what can I do to change within myself about that? So I thought it was neat to get that perspective from you to be like, yeah, maybe it's not just protocols. Maybe it's me that is instigating the conflict. So this was great. Thanks.
That takes a lot of insight, and that's an excellent comment to round out the show with, because maybe it's me, maybe I'm the problem, or the protocol, or the system, or or the department, that we get so insular, and we just, again, we got to get back to finding our common ground, and that's about the patient, and that we're all on team patient. So, hey, Timothy, congratulations, first author on your first publication, and you get to be on an SGEM Hop, your first podcast, the trifecta.
Oh, that last part was my favorite, actually.
Well, I hope you enjoyed this and didn't find that there was a lot of conflict.
Yeah, it's been good. Thanks for having me on. It's an honor.
And Lee, clearly you were a great supervisor and a great role model for the students there coming up through the program. So well done. Thank you.
I enjoyed it tremendously. Thanks.
So we only have one final thing, and that is for our guests to read the tagline. So what we'll do is we'll break it up, and so there'll be no conflict. Timothy, if you can read the first part of the SGEM tagline, and then I'll have Lee finish it up with the second half of the SGEM tagline.
Remember to be skeptical of anything you learn,
even if you heard it on the Skeptic's Guide to Emergency Medicine.